At times, it takes adversity to shine a light, to right what was wrong. Such is the story of Nancy Capello, a special education teacher from Connecticut. Nancy, according to published accounts, was what some doctors might call the ideal patient, especially when it came to those annual mammograms and self-exams that so many of us put off. So, like clockwork, in November 2003, she arrived for her 11th consecutive yearly mammogram and received a happy report that it was normal and that there were no significant findings. 6 weeks later, at her annual exam, her doctor felt a ridge in her right breast and sent her for another mammogram and ultrasound. Once again, the mammogram revealed no lump. The ultrasound, however, detected a large 2.5 centimeter lesion, almost an inch in size, which was later confirmed to be stage 3C breast cancer, a cancer so vile that it had metastasized to 13 lymph nodes. Understandably, the news brought Nancy, then 51, to her knees. She could not shake a nagging question, one that she posed to her doctor. Why didn't the mammogram find my breast cancer? That's when she learned she had dense breast tissue, making mammography less likely to detect tumors in her breast. Her breast surgeon estimated the cancer had been festering for 4 to 5 years under the radar of her mammogram. On a mammogram, dense tissue appears white. So do cancerous masses, making them easy to miss. Fatty tissue, in comparison, appears black, making tumors easier to spot. Nancy Capello died on November 15th at the age of 66 due to an infection related to a rare blood cancer caused by the chemotherapy and radiation she received in 2004. We're telling Nancy's story because she was the woman who launched a tireless campaign that led 36 states to require fuller disclosure to women about dense breast tissue, their mammogram results, and the limitations of the test. Welcome to the Healthy You podcast from North Shore University Health System, where we explore trending topics in healthcare. I'm Carolyn Starks, and today we're going to be talking with Dr. Georgia Spear.
I'm Georgia Giakoumis Spear. I'm Chief of Breast Imaging at North Shore University Health System and Assistant Professor of Radiology at the University of Chicago Pritzker School of Medicine.
Dr. Spear is an expert in dense breast tissue and has been instrumental in Illinois in passing legislation that allows women to receive information about their mammogram results, including whether or not they have dense breast tissue.
For me, I feel that the greatest asset to having the medical knowledge that we have is to use it.
She is leading a study to develop more specific national guidelines around the use of automated whole breast tissue ultrasound, a non-invasive procedure in which sound waves are used to scan breast tissue while a patient lies on her back with her arm over her head. Welcome to our podcast, Dr. Spear. I wanted to start by looking at 2 mammogram results. One is normal breast tissue. The other is dense breast tissue. So the mammogram of the dense breast tissue is as if you're looking up at a cloudy day and there's cumulus clouds and barely any blue peeking through. And then I look at the other one and I see it's just mostly just gray, some little white lines through it, but pretty clear. From what I understand, that the difficulty is that a cancer tumor would look like all these white spots. What do you see when you look at this?
What I see here is I see 2 images of different breasts, and they're both normal. In other words, they're normal for that particular patient. One breast is exactly that. It's very white. In other words, that patient has a lot of fibrous and glandular tissue, creating a white appearance on the mammogram. And if you can imagine, as we're trying to look for breast cancer as breast imaging specialists and radiologists in this field, we can't see through that very well because breast cancer appears as white, as does the breast tissue, and it makes it extremely difficult for an abnormality to present itself and for us to interpret it. On the other image, the patient has predominantly what we call fatty breast tissue. So there is a very small, if any, glandular component, and that glandular component again would appear as white. But in that particular image, you don't really see any white. You see a darker sort of image. And when we look at this, we can see through the breast tissue very clearly. It's like seeing through a very clear day. You could see better. And so we have more confidence in our interpretation of a woman who has fatty tissue type because we can find abnormalities more readily.
So what was it like for radiologists before this crusade years ago for increased screening for dense breast tissue after they reviewed a dense breast tissue mammogram?
That's a great question. And I recall the days when I was in training. And I remember looking at women's breast tissue on a mammogram and seeing dense breasts and thinking, gosh, you can hide so much in here, and you would never see it. And it would be so frustrating to know that we had no real good tool to circumvent that problem. And at that time, it was interesting because we used ultrasound and we used other imaging modalities. But even then, the technology wasn't at its prime. In other words, there was a lot of artifact, or maybe the images were noisy, or as radiologists in general, not everyone felt confident saying that, okay, if we add this to the test, that we're going to actually find cancers without calling back the patient an extraordinary amount of times. And so I think for me, this is the most exciting time to be in this field, because we've hit that point where there has been advancement in technology, advancement in image quality, knowledge, research that has helped us to get to this point where now we can make decisions on modalities that we can use to overcome this issue successfully. And that's exciting. And I think nowadays what we're seeing, because again, we now even have 3D mammography. So even mammography has evolved over the years, from film screen to digital to two-dimensional digital to 3D now. And with improvements in image quality, we feel more confident in making interpretations, but we also feel great about the fact that we may call women back less than we used to call them back, and we do. And I feel empowered as a physician to be able to make better diagnoses, and I feel empowered for every patient that we take care of, because now we have ability to see through that tissue more readily and make a better diagnosis and be able to find those breast cancers early, because that's our mission.
Hasn't it also been that the conversation, though, has opened up? So before, I imagine it was sort of medical, like shop talk about dense breast tissue, but now you're sharing this information with patients.
Absolutely. There's definitely been an evolution in the way that we practice in our field. And we spend quite a bit of time face-to-face with our patients, educating them on the importance of understanding their tissue type. And in fact, in the state of Illinois, we, have always practiced where in our mammography reports, we put in a patient's tissue type in that report. Patients weren't always aware of what that meant and what the implications were, but we put that into our reports. And more recently, in 2018, I was involved in the creation and passage of dense breast notification law in the state of Illinois. And so we created a specific piece of legislation that would allow us to educate all the women in the entire state about their tissue type. And so they would be notified on their mammography reports of their tissue type and the implications thereof. And the implications being that not only when a woman has dense breast tissue is it more difficult for us to find cancer on her screening mammogram, but dense breast tissue in and of itself raises a woman's risk for developing breast cancer. So it's very important for women to know that.
I think I read a statistic that said something like 40% of women have dense breast tissue.
Exactly. So it's a variant of normal. Every woman's breast is completely different based on her own intrinsic makeup, genetic makeup.
And can that change?
It can change over time. So about 40 to 50% of women would be placed into a category where they would have the two higher of four tissue type categories that we as breast imaging radiologists would note on a mammogram, and 40 to 50% of women would fall into these two higher categories, which would decrease the sensitivity for our test, screening mammography, which is the gold standard for screening to detect breast cancer, and again, raise a woman's risk for developing breast cancer.
Is fibrous tissue the same as dense breast tissue?
Well, that's a great question. So I think what you're getting at with that question is that when we see women with quite a bit of fibrous and glandular tissue, or what we term as dense breast tissue, those women tend to have fibrocystic changes or possibly small growths like fibrous fibroadenomas within the breast that we see on imaging, but fibrous tissue doesn't necessarily equate to dense breast tissue. Again, that determination is made by the radiologist on a screening mammogram when we use that lexicon we discussed to place the woman into a category for what type of tissue she truly has.
So it seems obvious, I guess, in hindsight, that increased screening would be the choice if you see a mammogram that has dense breast tissue.
So I think it's really important to just understand that medical management and practice guidelines evolve over time, and we're at that point now where we're really pushing the envelope. And especially at North Shore here, we're happy that we are pioneering in one of the largest supplemental screening programs in the country. We started this particular program 4 years ago. I am also concurrently performing as principal investigator clinical trials, prospective clinical trials, to evaluate the efficacy of supplemental screening so we could better understand how useful it really is to add supplemental screening to the gold standard, which is mammography for screening for breast cancer.
You know, I don't think we ever talked about what is supplemental screening. So if supplemental screening is suggested, then what does that mean?
Right. So above and beyond a screening mammogram, if a woman has dense breast tissue, which we discussed 40% of women may fall into this category, then a supplemental screening test may be right for that patient. At North Shore University Health System, we offer automated breast ultrasound as a solution to this. This particular test is complementary to the screening mammogram. It is not a replacement for the screening mammogram. There are important pieces of information that we obtain from a screening mammogram that cannot be obtained by any other imaging modality.
Right. So you don't want patients coming in, can I just get the
ultrasound?
Right. Exactly.
Yes, exactly. So no, we want patients to know, and we would like to make sure they're informed that the screening mammogram is the gold standard and every woman should have one yearly. But if you have dense breast tissue, a supplemental screening exam with an ultrasound, such as an automated breast ultrasound that we offer here at North Shore, would allow us to find more cancers and also give them reassurance that in this type of tissue, we are doing the best job we can to find breast cancer early. And we have seen some phenomenal results here at North Shore, which is why I feel that now is the time to really discuss supplemental screening to a greater degree and make sure that we provide the resources and the access for women to obtain it if they do have this tissue type.
When you say phenomenal results, do you mean you're catching things that were missed in the mammogram or not seen in the mammogram?
That's correct. So as we talked about, dense breast tissue inhibits our ability to find cancers, and it can limit our sensitivity down to 60%, 65% sometimes. And so when we add a supplemental screening test, such as an ultrasound, and in our particular case, an automated breast ultrasound, which is a 3D ultrasound, we are finding that we're seeing more cancers incrementally above and beyond the mammogram in patients with this tissue type. And the goal is to find clinically significant cancers, not necessarily to find cancers that we may or may not progress to something in the future. And what we're seeing is the cancers that we're finding that we're not seeing on a mammogram are small, they're invasive tumors, they are lymph node negative, and they're clinically significant. In other words, these are the cancers that would progress to advanced stage disease. And if we can find these small tumors using supplemental screening, there is no reason why we shouldn't apply this to women who have this tissue type to have that ability and that chance to find these cancers.
And these are tumors that they would not feel or a doctor could not feel.
Exactly. These are small, invasive tumors that it would take maybe a year, 2 years, or 3 years for them to even present themselves on a mammogram, just given their tissue type. And I think it's also important to note that with these advancements in technology, not only are we increasing our ability to find cancer, but because the imaging has become more optimal, we're also keeping that recall rate low. In other words, the amount of times we call patients back from an exam is really important to note, because we don't want to apply, again, a screening tool that we're going to utilize across a large group of women and then have them come back at a very high frequency for additional imaging that may not yield cancer. So we're finding in our research that the recall rates from supplemental screening are very low. The incremental cancer detection rate, which is the detection of cancer above and beyond a mammogram, is respectable. In other words, we're finding several tumors that are not seen and they're mammographically occult or hidden. And so this propels us to keep moving forward with this movement.
Speaking of this movement, I know you've been instrumental in Illinois and other states. I think you're also providing support for legislation. So what inspired your journey?
I think this all goes back, which is interesting now because, prospectively, I never saw this, but retrospectively, when I was a college student in the pre-medical curriculum, my aunt, my mom's youngest sister, was diagnosed with breast cancer, and she was 39. And she was diagnosed with an advanced form of breast cancer, and upon remission, had symptoms and ended up being diagnosed with stage 4 disease and subsequently passed. And interestingly, in the course of my education and my training, I've always felt that I wanted to help women somewhere along the way, but I was also very interested in using my hands and performing procedures and whatnot. So my course wasn't necessarily traditional, but I ended up in breast imaging, where not only do I feel very personal connection to this particular mission, but I also am able to perform interventional procedures, and I'm challenged every day, and I do feel like we're doing the right things for women today.
When you saw this dense breast tissue, you saw this probably trending as an issue. This is becoming bigger and bigger and bigger. What prompted you then, I'm going to get in the forefront of this?
For me, I feel that the greatest asset to having the medical knowledge that we have is to use it and to really put ourselves out there at the table for the discussions. Sometimes they're difficult and sometimes they're not easy because not everybody may see things the same way. And it's really our goal to use our medical expertise and our experience in medicine to propel things forward. So it's a personal mission of mine to be present for these types of things, because not only do I care about the patients I take care of in my clinic, but I really think if we can impact more women and be able to find more cancers across the state. With this breast density legislation piece, we're notifying women, but in Illinois, we also have a mandate for reimbursement for supplemental screening. So it's important for me to fight for these sorts of things because women in urban areas may have access to supplemental screening, but what about those that live in rural areas? And for us to have that legislation piece in place means that it will require women to not only be educated, but to understand where they can go and what imaging tests to ask for or ask about to see if they're right for them.
So what's the new legislation coming up in January for Illinois?
So I'm very excited about this particular piece of legislation that recently passed through the House and Senate, and Governor Pritzker just signed it, and it's going to go into effect on January 1st of 2020 in the state of Illinois. I was asked to serve as the medical expert to support a legislative piece that is going to cover diagnostic mammograms as part of wellness. In other words, when a woman comes in for a screening mammogram, and we may or may not be able to make an accurate diagnosis without some additional views, we may call her back and she may need some additional mammographic views, and we call these diagnostic views, a diagnostic mammogram. When a diagnostic mammogram is ordered, it is placed towards a patient's deductible. So there may be out-of-pocket costs that a woman has as a result of this. And so this particular legislative piece is going to cover diagnostic mammograms without out-of-pocket costs. It's not going to incur a copay or coinsurance or any cost towards the deductible. This will be paid for by insurance. And we are one of the first states to pass legislation of this kind. And I think this is really exciting because the goal is to make sure that women come in for their screening mammograms and they're compliant with annual screening for their best case scenario for early detection of breast cancer and to make sure that women do not die of this disease.
That's amazing. I mean, you literally just removed probably the biggest barrier that a woman would have to getting that diagnostic or supplemental screening.
Exactly, because in order to reach all the patients in the state of Illinois, most women can't afford these tests. They can be several $100 out of pocket, sometimes $500, sometimes $600 out of pocket. And then what happens is they avoid the recommendation to return because of the financial hardship. And so removing that economic hardship, I think, is going to be huge. And it's going to make an impact on having women come to get their screening tests as recommended to give them their best chance at early detection.
Can you walk us through what a patient's experience would be if they came, say, to a North Shore office and you were the radiologist and saw dense breast tissue. Walk us through then what the notifications would look like and so forth.
Of course. And so, again, 40% or more of women that we screen have dense breast tissue. So once we actually perform a mammogram on a woman and determine that she falls in the higher two categories of density, those are reported on her mammography report. Furthermore, in the mammography report, we place a...
Does she receive that report?
She does. Okay. I'm sorry. Yes, her referring physician and the patient will receive that report. Okay. And in that report, it explains dense breast tissue and the implications thereof, which we discussed. And it also states that a supplemental screening exam with ultrasound can be helpful to circumvent the limitations of mammography in this particular setting. So that particular piece is in the letter that the patient receives, as well as the referring physician.
Does she also get a phone call or?
Not necessarily, okay. Not just for dense breast tissue. I mean, it would be something that her physician would follow up with her on. And when she'd come in for her next screening exam, she would be scheduled for a supplemental screening test as well. But it's also important to note when you create a program such as this over 4 years, it's important not only to just educate the patients, but to educate the referring physicians who are sending the patients to us, to understand the evidence-based medicine behind the practice, to understand the modality that we're using, and to furthermore be updated on the continued results that we're receiving from our internal research as well as research across the country and across the world, quite frankly.
Is there anything else you'd like to add, or where can people go for more information?
I want to add that it's extremely important for women to know that early detection saves lives, and mammography is the gold standard for screening for all women for breast cancer, starting at the age of 40 and annually if a woman is of average or intermediate risk. If a woman has a strong family history of breast cancer or concern that she may be at elevated risk for developing breast cancer, it is important for her to have that discussion with her provider. They would send her to a high-risk clinic to have an assessment, because women who are at high risk have different screening regimens and different imaging modalities that are used at different frequencies to make sure that she is getting the right screening regimen. But for average and intermediate risk women, it's really important for them to start at the age of 40, have an annual screening mammogram, because we know from randomized control trials for decades and decades that screening mammography saves lives by decreasing mortality from breast cancer.
Thank you so much for talking with us today. Such an important topic, and you've been instrumental in getting legislation passed, and I'm sure this is going to help a lot of women.
Well, I appreciate the time, and thank you so much for having me.
And to those listening, I'm so glad you were able to hear from Dr. Spear and this important information she has to share. And if you or someone you know needs a mammogram or is interested in knowing more about ultrasound, you can contact North Shore at 888-364-6400 for scheduling, or go to northshore.org/mammogram. And thanks.